Hello, this is Dr. Alan Lumsden. We're coming to you from the studios of the DeBakey CV Live. And I'm joined today with two people I've worked with during the course of my professional career. Dr. Chris Smolock, who's currently at the Cleveland Clinic, and Dr. Chip Sternbergh, who's the Chief of Vascular Surgery at the Ochsner Clinic in New Orleans. Now, they're both wearing Methodist scrubs today because they've been helping with this inaugural ISEVS Hands-On Symposium. So, first of all, thank you both for coming down and helping run this course, and thank you for agreeing to be subject to the questions. So we're talking before we went live on what should we talk about, and one of the things that came up is I worked with Chip when he was a fellow at Emory in 1995, and he tells me that the most advanced endovascular procedure we did was?
Yeah, I think it was an angioplasty of a venous anastomosis of an AV graft, and that was a big deal, and no one thought that was a great idea at all at the time.
So it's interesting because one of the ways I got into the endovascular world through was another fellow at Emory, a guy called Steve Owita, and he had gone to the Arizona Heart Institute and had watched Dr. Ted Dietrich. Many people don't know that Ted Dietrich started, first of all, he started ISEVS, but he went to Arizona Heart from Methodist Hospital. How Ted went from an institution that was all about big time open surgery to create a minimally invasive empire is beyond me. And that's really was the genesis for me trying to get into this. We were looking for a safe model that we could learn this, and that was the AV grafts. And Chris, let me introduce you. We worked as a fellow here at Methodist in 2010, and life had changed at that point in time. What kind of endovascular procedures were you doing?
I think probably for the most advanced that we had done was image fusion and guidance, fusing a CAT scan with the patient live on the table and angiography and targeting vessel lesions like this, for example, a type 2 endo leak. We'd started to get
9 years ago we were doing that.
Yeah.
Wow, that's interesting. So Chip, you wrote a paper and you're renowned for coining the phrase endo exuberance. Are we going too far in the opposite direction?
Yeah, that was a paper from a long time ago, endo exuberance to endo reality, and that was published in, I think, 2003, 2004, and it talked about our rush to fix aortic aneurysms with endografts, and finding that at least at that time and period we were probably pushing the envelope too hard and had some outcomes that really weren't great, and that we needed to sort of rein it back a little bit. It's amazing looking back now, almost 15 years later, the devices that we have available now are so much better than those first generation devices that we can safely treat people that we wouldn't have thought. Well, we thought we could treat them safely, but we just didn't know any better back in the early 2000s.
So exuberant no more?
Well, I think endovascular therapy is clearly here to stay. It's the dominant form of therapy for vascular disease. Open operations, I don't think are going to completely go away, but boy, they certainly have gotten a lot less common than they were even 10 years ago, and certainly 20 years ago. It's a dramatic change, and I don't see that clock being turned back.
So Chris, you guys turned the clock way forward. I mean, you're in the mecca of where branch stent grafting evolved. I guess Roy's legacy was around developing the branch endograft program. So what's happening at Cleveland Clinic in contemporary times?
So what's happened is that a lot of that technology, as you know, has been disseminated and it's being done in a lot of other places. And I think somewhat we have turned back just a little bit to doing more open operating. And I think being ahead of that curve at one point with endovascular procedures, we've seen the failure modes. I think that was a prescient article that you wrote. We see those failure modes, and we see maybe we can choose between these two methods or combine them in a hybrid method, and what's going to be best for that patient based on how sick they are, how healthy they are, how young they are, what do they need for durability, etc.
So let me just pick up on what you said, because you picked up on the endo exuberance part. I mean, for the trainees, I often say, make a title a little provocative. Now, you better have the data, to validate your position, but there's nothing better when you're a program director and putting a program together. You really want somebody who's going to hang it out there, because you just know that the conversation that's going to happen after that presentation is going to be kind of wild, and conflicts occur, but it's what makes these programs entertaining. Why'd you choose that?
Yeah, well, for that catchy title, and that it is attention grabbing. Frankly, I don't remember what. I'm sure we presented it at a meeting. I don't remember which meeting. The journal that we ultimately published that in was Journal of Endovascular Surgery, or Endovascular Therapy now.
Oh, wow.
Okay, and I think it was actually so controversial that they put it. They wouldn't put it as a regular article, but they made it as a editorial because they thought it was so controversial.
Did you get a bunch of flack from industry?
It wouldn't be the first time.
Oh, that's fascinating. So, I mean, right now at Cleveland Clinic, what happens? You know, you're doing branch grafts, fenestrated grafts for thoracoabdominals?
We are. Patient comes in and they sort of get evaluated by the aortic center. So it's a combination of vascular surgeons, cardiac surgeons, and cardiologists.
So tell us how that works, because we're very interested. So patient has an aortic aneurysm, okay?
Yeah.
Lots of patients have aortas, we hope. And so patient comes in with an aortic aneurysm. Let's say it's an infrarenal aneurysm.
Yes.
Everybody sees the patient?
For a patient like that, no. That patient comes to vascular surgery.
Okay.
But
a thoracoabdominal.
But a thoracoabdominal will be seen by everyone, particularly if it's an acute aortic
So
syndrome.
the patient comes into the clinic, and in that clinic that day there's a vascular surgeon, a cardiac surgeon, a cardiologist?
It goes into it goes into a center for scheduling, and goes to one of those people with backup appointments with the other people.
Okay.
And then the team really gets together on every single patient in real time in our CCU, which is kind of like a triage center for all acute coronary and acute aortic syndromes. And decisions are made based on that. But I would say if we take just the infrarenal aneurysm that's coming to the vascular surgery clinic, the group of us have kind of come to some decisions around age and neck to how we're going to treat that patient.
That's fascinating. Yeah. So the conflicts, the people agree?
There have been
We noticed the pause.
conflicts
There was a
over
pause.
time. There have been conflicts over time. I think we have kind of agreed, or whether in a de facto way, about, I'd say, around the age of 70. If we think it's based on older technology, but around 8 to 10 years, if you kind of look at durability, the need for additional procedures with endografts, we kind of put that into the pot. How the patient looks, from a cardiopulmonary standpoint, from a functional standpoint, and if they're in their 60s and we think that they may live for another 10 to 20 years, then we're seriously considering still doing an open aortic repair on that patient.
Interesting. So we have a complex aortic conference where multiple disciplines come together to review it, but we don't really all see them together in one clinic. We've certainly talked about it. The other thing we do is we have with Bill Brown up in Beaumont, we have an aortic teleconference. They're structured very similar to us in that they have cardiac surgery and vascular surgery and basically in one department, and we present remotely. We just present cases. Do you do anything like this?
Well, it's probably not quite as structured as that, but certainly with the thoraco or difficult aneurysm, we're going to get opinions from the cardiac surgeons and decide what we think is going to be the best way to tackle it. I think it's fascinating that at a center that really has been the vanguard for pushing advanced aortic endografting, that you're now coming back a little bit, and particularly for those younger patients that you think have a long life expectancy. Your institution has that data and that institutional memory of knowing that bad things can happen later in down the road. So that, and I think in an age where this branch technology is being pushed beyond just a handful of centers, and people are saying, well, boy, if we're not doing that, we're kind of in the dust. what this tells me is that people they shouldn't abandon the scalpel yet. And I think some of us have never gone quite that far, that endo exuberance, if you will. The important thing is to have a balance. And I think you're right. If you have somebody in their late 50s or early 60s that you think is going to be with us for another 20 years, you better think about what's going to be the most durable. But then it does come down to what their upfront risk is.
Yeah. Well, we've seen, other patients who have had, even if it is just a simple infrarenal endograft, and those patients, for one reason or another, are lost to follow-up, and I'm sure we've all seen that. Those are the patients that come in extremis with a problem. And if you don't keep that good follow-up, they're going to have a problem. But also keeping that good follow-up for 10 to 20 years of CAT scans, radiation, extra procedures.
All right, great conversation. Chip, I neglected to mention that you're the president of the Southern Vascular Society, which is the most prestigious of the regional vascular societies. What are you going to talk about? Is it a big secret where your presidential address is? You want to make a pitch for the Southern?
It's, I'm working on that talk.
Sounds like it may be something to do with endo exuberance.
No, it's probably not going to be.
Oh.
It's probably going to be something a little bit more ethereal than that.
Ethereal. All right. Well,
but I would say that it's going to be a fabulous meeting. It's at a fabulous location. I mean, the Breakers is, I think, top of the blocks for just about any resort.
You got to come, Chris.
I will be there because I will be there.
Well, thank you both for spending time here. Thanks for supporting the ISEVS, and thank you for watching this.